So I'm speaking about emerging new phenotypes. These phenotypes always have existed, but recently the research have put a light on them. So I don't have any disclosures pertaining to this talk. So let's talk about the objectives. So I'm going to tell you why emerging phenotypes, are need to be talked about today. How are we going to discuss that? And finally, where exactly we can find the clinical utility and where they exist, in the guideline statements. So there is underdiagnosis and undertreatment of ischemic heart disease in women around the world. And this happens because women present with other symptoms, even though chest pain is the predominant symptoms, they present with excess of other symptoms. They tend to be ignored because of the presence of other symptoms. There is delayed presentation. They try to ignore their symptoms. There is delayed treatment. There is traditional and hormonal risk factors related to pregnancy and menopause that are seen in women. There is perceived lower risk by the physicians when women present with ischemic heart disease. They also have autoimmune risk factors related to SLE, rheumatoid arthritis, etc. And women also have less clinical trial participation. So we don't have that much data for women worldwide, not just in India. And finally, but not the least, is the societal bias and the physician bias that exists when it comes to diagnosis of ischemic heart disease in women. So if we look at the latest ACC/AHA chest pain guidelines, which Dr. Greenwood is in the audience, he was one of the authors on that. The chest pain guidelines put equal emphasis on anatomical as well as physiological testing of ischemia. And I will tell you why that may not be a preferred pathway for particularly, for women. So, of course, when we look at the CT data, Scott Hart trial showed that women that presented with chest pain, most of them had normal angiograms or normal anatomical testing. Then followed by that, they had, as you can see there, they had more non-obstructive CAD, and the obstructive CAD was way less compared to men, where obstructive and non-obstructive CAD was found to be higher in percentage. Even when we look at the confirmed trial registry data, when they took all the patients without any known CAD for women, as you can see, as the severity of coronary artery disease increased, there was worse mortality. So even if women have non-obstructive CAD that does not present a benign phenotype, it actually adds to the mortality risk, even if that diffuse CAD is in multiple vessels versus one vessel. So non-obstructive CAD cannot be discarded as nothing is wrong with the cardiovascular system. Particularly, again, if we look at the MESA trial, MESA data and consortium data, similar conclusions were made that multivessel CAD is higher in women when we look at diffuse multivessel CAD. And in spite of having diffuse multivessel CAD, women overall have higher plaque burden, and hence they have higher risk of mortality or cardiovascular events from that non-obstructive diffuse CAD. So what I've shown you so far is, of course, anatomical evaluation of CAD by cardiac CT is essential in women because it tells you about the plaque burden. Because plaque has a sex-specific signature. Coronary atherosclerosis is quite common in women. And even though it's diffuse, non-obstructive CAD drives the mortality, and it's important to identify, evaluate, and treat female patients with atherosclerosis when it is found. But remember that there is significant women population that presents with no plaque at all, and they yet have chest pain. So what do we do about these patients? If I was a patient presenting with chest pain and I have a negative cardiac CT or angiogram, I still would like to know what is driving my chest pain, particularly when that chest pain is presenting as classic angina. So this is a very powerful table or graph that I show you here. But look at this. So this is a graph. It shows fractional flow reserve. fractional flow reserve right here and the luminal stenosis. And you can see that on the left lower quadrant, when patients have no luminal stenosis or zero non-obstructive luminal stenosis, yet they have significant FFR. And, thank you. These patients, present still like 20 to 30% of patients with ischemia. So only 1/3 of the women that have anginal symptoms have obstructive CAD. And if we look at presence of ischemia without or with non-obstructive coronary artery disease, which is also known as INOCA, it's seen 65% in women versus 32% in men. And actually 60% of these patients that come with INOCA, they have documented CMD. And CMD is the one that has been associated less with the traditional risk factor, but more with age. So what is INOCA? So INOCA is syndrome of patients either with symptoms or signs of ischemia, but when they don't have a no CAD or non-obstructive CAD. There are many types, endotypes that we are going to see, but we are going to predominantly discuss the microvascular dysfunction or coronary microvascular dysfunction, which is defined by coronary flow reserve, which is also known as CFR. So we're going to discuss predominantly that. So just if we look at the Indian population, of course, the same, challenges remain. So 1 in 3 women in India die of CAD. There is excessive risk factors. There is societal and physician biases. There is no clinical trial data, and there is extensive undertreatment of women when it comes to coronary artery disease. So let's look at the traditional stress tests that are out there, and how do we figure out if evolution of INOCA can be done by these stress tests. So exercise EKG, the positive predictive value is only 47%, and that is because there is excess catecholamine release, and there is a estrogen effect. So estrogen has kind of similar molecule type as digitalis, and women tend to have more STT changes because of that on exercise EKG, but and then they miss the diagnosis. Similarly with SPECT MPI, there is lower sensitivity, and that's because women have smaller heart, they have higher EF, there is low specificity, predominantly because there is breast attenuation, and if you don't have attenuation correction, again there can be a higher chance of false positive testing with women. And again, with stress echocardiography with women, there is poor negative predictive value, predominantly due to higher flow and higher EF that is seen in women. Let's see. So there are some sex differences in coronary anatomy and physiology. So what I mean by that, so women have smaller epicardial vessels. They have less obstructive but more diffuse coronary atherosclerosis. They have higher blood flow. So even with smaller vessels, they have higher blood flow, which puts shear stress on those coronaries. And then they have lower vasomotor tone. They have less LV mass, yet have more LV contractility, and that's why we see more heart failure preserved EF in women. They have larger LV EF, and overall they have lower myocardial mass to coronary volume ratio and blunted coronary vasodilator response. So due to all these factors that are very different between the two genders, I think that there is more shear force on the small epicardial vessels that are seen in women, and they tend to have coronary microvascular dysfunction. So let's talk about the second part, which we have talked about why we need to talk about these emerging phenotypes, but how are we going to diagnose it? Because I just showed you that that traditional stress testing may not work in women because of the poor accuracy. So, of course, it comes down to this, extensive microvascular network that we have. And it's not just epicardial vessels, but we are talking about this part, which is the microvasculature of the heart, which gets affected in women. So let's talk about the INOCA endotypes. Again, ischemia without non-obstructive coronary disease. So there are two endotypes. One is because of there is more vasoreactivity in women. And in this category, you see epicardial spasm, and then you see microvascular spasm. On the other side, you have impaired vasodilatation. So impaired vasodilatation leads to endothelial independent and endothelial dependent coronary microvascular dysfunction. So this is what we can diagnose non-invasively, versus this on this side needs coronary hemodynamic testing, particularly with acetylcholine testing. So again, what we are going to focus today is coronary microvascular dysfunction, which is predominantly, a function of the microvasculature and can be measured non-invasively or invasively. So how do we diagnose CMD on a non-invasive testing? So we have two tests. One is PET and another one is stress CMR. And again, coronary flow reserve would be known as myocardial flow reserve when we look at the non-invasive testing, because we are not measuring directly coronary flow reserve. So myocardial flow reserve of less than 2 has been associated with worse outcomes. You can see this graph that's from one of my friend Venk Murthy's circulation paper, but it has been associated with a worse mortality. So this is an example of a stress PET. So you can see right here, this is the rest and stress PET, and you can see that you can also assess the wall motion. You can assess the EF. This is a completely normal PET. And when you look at the flow, you have the normal flow reserve, because what CFR measures is how much the coronary flow can increase during stress. And in this case, it increases more than double, which is what we should see every time we stress our patients. So now this is an example where you have normal PET perfusion. So when you look at the color, there is no defect that you can see. Yet when you look at the CFR data, there is abnormal CFR data in the vessels. So this is where, you can say that there is no perfusion defect. So perhaps there is no macrovascular dysfunction, but there is definitely evidence of microvascular dysfunction. And this is on stress PET. Of course, my favorite modality cannot stop talking about stress CMR. So stress CMR, the myocardial flow reserve or myocardial perfusion reserve index has been still in the research phases in most of the centers in United States, but there can be a visual component. So here you have stress and here you have rest. And I've just given you the still shots right here. So you can see that there is a perfusion defect in the, subendocardium. So in the absence of obstructive CAD, that circumferential inducible ischemia in the subendocardial layer of the myocardium in the ring fashion, that suggest, coronary microvascular dysfunction. Of course, visual assessment is very subjective, as we all know, and it does not tell you the severity of CMD. So what we need to look at more objective data, and this is a new automated pixel-wide quantitative myocardial perfusion mapping that is becoming more popular because it's easy to do and it's in line. So directly on the scanner, you can see, whether the flow is normal or whether it is abnormal, because it gives you the numbers for every myocardial segment. So again, here you can see with stress, the flow is increasing threefold, while in this case, some of the myocardial segment, the flow is only increasing 1.8 or 1.4 fold, and the flow should increase double, in simple words. So there is a protocol. So in the protocol, of course, CMR is a one-stop shop. So you can do cine imaging, you can do mapping, you can do stress perfusion, then you can do rest perfusion, and finally you'll do late gadolinium enhancement and ECV. And with one test, you are able to figure out if there is any evidence of previous myocardial infarction, if there is any macrovascular perfusion defect, if there is microvascular dysfunction. So I think, to me, this is a complete test, without wasting much resources. So let's look at a case. So this is a 46-year-old post-menopausal woman with pre-diabetes. angio is negative. You can see that she has some circumferential visual perfusion defect. It can be hard to diagnose this, I'll be frank with you, and that's why we need more objective assessment. And she had myocardial perfusion reserve index of 1.6. So I think the third thing is where exactly all this fit with the new guidelines. So very thankful to the new chest pain guidelines because they devoted an entire section on ischemia with non-obstructive coronary artery disease and actually mentioned that, women who present with chest pain are at risk of actually being misdiagnosed, and hence a complete history should be taken. And further, both stress PET and CMR got a 2A recommendation for women that are suspected to have INOCA. So this is further, they present an algorithm when you suspect the patient with INOCA, particularly women, but also can be seen in men. You look at, you either go for invasive coronary functional testing or you go for stress CMR or stress PET. Of course, in my patients, I prefer this first. I want to see if there is a CFR data that I can obtain. And there are patients where you may not get any answer by non-invasive testing, where you can move to the invasive coronary functional testing. So I think that what I have shown you so far is women have multiple risk factors that are, beyond traditional risk factors. The, regular atherosclerotic cardiovascular risk assessment that we all are used to doing that may not apply in women because it does not take care of these excess risk factors. And when women, come with chest pain, of course, anatomical testing, particularly just with coronary CT, not with cath, can show you the plaque burden, which can allow for plaque modification early on in life. And if the patient does not have any obstructive CAD, then further ischemia evaluation where microvasculature can be tested is preferred. So of course, if we look at the risk of major atherosclerotic cardiovascular events, obstructive CAD has more MACE compared to, ischemic CAD, yet it is important to give our patients that answer. Why do they have anginal chest pain? So I think my take-home points for you are focus on obstructive CAD is no longer adequate, and coronary microvascular dysfunction is common in both the genders, but particularly women with chest pain. Effective diagnostic testing needs to identify patient at higher risk of events. We are not looking for anatomically obstructive coronary disease. We are looking for patients that have higher cardiovascular events without over-testing those that are at lower risk. And finally, diagnostic clarification of coronary microvascular dysfunction may help to avoid costly, unnecessary additional testing and better define the disease to develop evidence-based management and prognosticate CAD for our patients, particularly women. Thank you very much.